Now these are well stated in athletes also. All right. So again, pain, swelling, weakness, numbness, morning stiffness, stiffness after inactivity, deformity, instability, and also your loss of function, loss of motion. So usually for pain, you know what to ask. Here you all use Socrates or you all use as a COPD Sarah. Socrates, just follow your Socrates. But for all the others, the complaints, usually my template is onset, cause, duration, management, and associated features. Alright, because for example, if you go for your off-tau, red eye, tiba-tiba you like, chua, and don't know what to ask, just go through the same template. When is the onset? How is the cause? How is the duration? How has the patient been managing this red eye? Any other associated symptoms? Just as simple as that. You'll be able to get most of the information out. Alright, and then one of the tips during your history taking is that just ask the patient, ask them to tell you. For example, during my recent cases, it's a very complex cases and all that, then just ask, so what did the doctor say about your x-ray? What did they tell you? Right? So you say you did the operation. What did the doctor say? What operation was it done? And after that, if they are still suffering from some complications, for example, limb length discrepancy and so on, ask them, so what did the doctor say about your limb length discrepancy now? Are they going to do anything about it? So you know that your management should not go too far away from whatever that is proposed for this patient already. Alright, for example, if he is doing quite well with his LLD of about 2 centimeter only, and then the doctor is not doing anything, then tiba-tiba in your management you say you want to do extensive surgery for this patient, you know you are running very, very far away from what is actually being practiced. So just get the tips from your patient. They're going to tell you what is the correct, appropriate management for that. Alright, so usually when I summarize my history, I'll go in this summary. Alright, standard template. This is a 1-year-old, 35 or 45 years old, lady, gentleman, boy or girl, with underlying what and what? Underlying bronchial asthma under control. Just a very simple one. With underlying diabetes on medication, who presented with 5-year history of chief complaint of right knee pain and instability, for example. Alright, now usually you just put 2 or 3 like that. There will be a main chief complaint. Usually, for example, knee OA, you have pain as a main complaint, probably associated with instability. If you got a shoulder pain and probably weakness. Alright, so there will be some associated symptoms. Just mention these 2. Then associated with. Alright, associated with what? Standard sentence at the back is associated with difficulty in what and limitation in what. Alright. So for example, 45-year-old lady with underlying rheumatoid arthritis who presented with 7-year history of progressive right knee pain and instability associated with difficulty in walking and limitation in daily activities at work and at home. Full stop. That is the first sentence for your history. Followed by expectation-wise. He or she hopes to achieve. Right? So usually hopes to achieve restoration of stability or hopes to improve the gait efficiency. Hope to achieve pain relief. Okay? So summary, just as simple and as short as that. Alright, especially in ortho, we are very, very interested to know what is a functional limitation because that will guide our management. Alright, so that is a standard 2 sentences to summarize your findings, and then after that for my physical examination, relevant positive findings include what and what, which I'm going to teach you. Okay, alright, so we're going to start with the cervical myelopathy. Look, feel, move, standard lah. Alright, for orthopedic. So probably just stand here first. So on general inspection, patient is standing comfortably without any walking aid. Sometimes cervical myelopathy, they can have gait instability. They may have a walking aid, so you need to inspect that. But otherwise, nothing really much from the front, alright, for cervical myelopathy. Now from the side, you look, is there any loss of cervical lordosis? Alright, now cervical lordosis is like this. Okay, that's why you see, you sleep on a pillow and all that, right, because of your curve of your cervical spine. When there is a degenerative, for example, cervical spondylosis, there will be loss of cervical lordosis, will go straight like that. Okay, alright. So there is no loss of cervical lordosis, normal thoracic kyphosis, and normal lumbar lordosis. That's your sagittal alignment. Okay? Now, then after that, you look at the back. What are you trying to see? From top to bottom, go systematic. Neck, any neck tear. Alright? No neck tear. Shoulder appear to be balanced. Any cutaneous stigmata, for example, neurofibromatosis, or any evidence of a spinal dysraphism, patch of hair, and so on. Alright? Then after that, you say you palpate, feel. Okay? Look, feel, feel finish. Look finish already. So you feel any increase in warmth compared to the surrounding area. Then after that, you palpate. Alright? Palpate, the one that really, this one is that, I hope that when you palpate, go a bit more slower. Alright? Because even my colleagues, even at the master student level, they try to rush it through because they're afraid that they do not have time to finish the examination. But they look a bit too rushed, in my opinion. For example, when they palpate, I think it's a bit too fast already. Just go slowly. Look at the patient's face. Kalau sakit, bagi tahu saya. Okay? Okay? Alright. Just go slowly. Okay? And then after that, palpate for the paraspinal muscle tenderness. Alright. Now, for the movement, usually you just ask them to follow you. Okay? For all the like shoulder, all the other movements, just ask them to copy you. Alright. So, sekarang saya nak you gerak you punya leher. Alright. Sampai bawah berapa banyak boleh sampai? Okay. Tengok atas berapa banyak boleh sampai? Atas. Okay. Tengok ke belah kiri. Tengok belah kanan. Okay. Telinga kiri sampai bahu kiri. Okay. Sebelah pula. Okay. Alright. So that's a ROM. Flexion, extension, lateral flexion, lateral rotation to the left, rotation to the right, lateral bending, right? Now, in cervical spondylosis, they will have restricted range of motion, all right? Most likely in globally, all right? Global means in a lot of different planes, all right? So I think it is a very nice sentence to summarize. You don't mention one by one, flexion from 0 to what, extension, no name. I think, in my opinion, is after you check out, there's a global reduction of the cervical range of motion in all directions. Sounds better. Okay? Alright. Now, after look, feel, move, you ask the patient to walk. Okay? Boleh jalan pergi sana? You ask the patient to walk without the shoes. Always without the shoes. Ask the patient to walk. And as far as possible. Otherwise, very short, very difficult for you to see what is actually going on with the patient's gait. Alright? So, walk one time as far as possible. What you're trying to see is there any instability, any broad-based gait? Then after that, when they come back, you ask them to walk like this. Tandem gait. Heel to toe. Heel to toe. Alright. In cervical myelopathy, they won't be able to do this. They will tend to fall down because they will have a broad-based gait. Okay? Alright. So, after the gait, then after that, you ask the patient to sit at the edge of the couch. Alright? So, the first thing you're going to do is to ask them to do this. Okay? So, what I'm trying to do is the finger abduction side. Alright? So, this is abnormal. Alright? Indicating that there's either radiculopathy or myelopathy affecting your C8 or T1. Alright? Okay, they do this. Okay? So, there's no finger abduction side. The next thing you're going to ask them to do is do this one. What is this test called? Grip and release test. How many times in how many seconds? 20 times in 10 seconds. Alright? So they will have loss of this manual dexterity and they won't be able to do that. They'll go quite slow. Alright? Okay. So then after that, you check your neurology of your upper lip. Alright? So go by standard tone, power, reflex, and then sensory. Alright? So tone, flexion, extension, shoulder forward flexion, extension, pronation, supination, flexion, extension, flexion, extension. Just roughly to see. So how is the tone like? Alright. Then after that, you're going to check the power. So C5 to T1. Alright. So 1, C5 is like this. Jangan bagi saya tolak ke bawah. This is C5. This is also C5. Alright. So buat macam ni. Jangan bagi saya tolak ke dalam. So when you comment on the MRC, you are not comparing to yourself. You're comparing to the contralateral side. Similarly, in anterior drawer, posterior drawer, that's for your knee ligament, it is also comparing to the contralateral side. It's not comparing to your side, your own ligament. Alright, understand? Alright. So C5 jangan bagi saya tolak. Jangan bagi saya tolak. Okay. Jangan bagi tolak kuat. Tolak kuat. What am I testing now?
C7.
Yes, correct. C7. Alright. Now, I don't go like C5, C6, C7 because I feel that this is much more smoother, the flow. Once you do this C5, then you do C7 straight away. Alright. C6 is like this. I will give the instruction. Buat macam naik motor. Macam naik motor. Okay? You go up, naik motor. Jangan bagi saya tolak ke bawah. This is C6. If not, you do like this. Then you ask them to do like this. Then you ask them to do like this again. I mean, see, okay. Definitely see acceptable. But, you know, it's not as smooth for me. Alright, so C5, C6, C7. Alright, C8, how do you check? Finger flexion. Alright, finger flexion. Pegang kuat-kuat, jangan lepas. Okay, pegang kuat-kuat, jangan lepas. Kemudian NT1, ask them to open up all, finger abduction. Jangan bagi saya tutup. Okay, alright. Now, when they can't, then after that, you eliminate the gravity. For example, C5, they can't do like this. So you ask like this. C5, C7, C6, they can't do like this. You ask them to do like this. Okay? C8, they can't do like this. You ask them to do like this. Just eliminate the gravity. Alright? And then T1, usually no need like T1 is just like that. You don't have to really go like that. It's T1. Alright. So, tone, power, and then reflex. Okay? So, reflex, C5. Here, biceps. Look at the biceps contraction here. Tap. Alright? C6 here, at the brachioradialis tendon. Okay. Now, the way to interpret this C6 is that the normal reflex, your normal brachioradialis reflex should be like how? If you tap, you go like this. This is your function of your brachioradialis, isn't it? So that's why if you tap on your biceps, biceps is responsible for elbow flexion, you go into flexion like that. Brachioradialis, in this position, you'll go up a bit. C6. Alright. However, it is considered an upper motor neuron lesion, alright, when you have what we call inverted radial reflex. Heard before? Inverted radial reflex, whereby you tap on the brachioradialis tendon, it doesn't go do this, but rather you do this finger flexion, like your Hoffman sign like that. Okay. That's finger flexion. That's inverted radial reflex positive. Then after that, you check your C7 reflex. Okay? And then after that, you check your Hoffman sign. Hoffman sign, you relax the patient elbow, relax the wrist, and then after that, hyperextend here, alright? And then use the thumb here, quickly, just go down. And after that, you are looking for finger flexion, index, thumb like that, alright? So that's considered an upper motor neuron sign as well. That's a Hoffman sign. Alright, so let's say all these are positive. Alright, all these are positive. You want to determine where is the level of your pathology. Alright, cervical myelopathy can be from C1 to C7, the Ds, alright. Usually it's C5, C6 there lah. That can be higher up also, but rarer. Alright. So because your sensation you check until the highest level C5 only here. Alright, so you do know higher is like how. So what do? Reflex. Yes, scapulohumeral reflex. Alright. It's also called a Shimizu reflex. Alright. So when you tap, you will see a lot of books. They will say tap on the spine of the scapula. And spine of the scapula is this at the back here. Alright, there's one spine like that, a ridge. Alright. So they'll ask you to tap on that. However, during our master training and all that, it has already been revised. Alright. So you actually tap on the supraspinous fossa, tap on the tendon. Now, because the rationale behind it is that you see for all the other reflexes, you're actually tapping on the tendon. Right? So why this one you're tapping on the bone? Right? So you note here you got a supraspinatus tendon at your supraspinous fossa. So just slightly above the spine of the scapula, you put your finger there and you tap. If there is an upper motor neuron lesion, the shoulder will go into abduction. It will go struck like that. It will go out like that. Alright. So that is C4 and above. You've got a pathology C4 and above. But can stroke, can brain tumor give you upper motor neuron lesion? Can, right? Alright. So how we differentiate that from the cervical cause? Anybody know? Yes, we do Georgia reflex. Alright, so Georgia reflex is mediated by both C5 and C7. Your cranial nerve 5 and cranial nerve 7. Alright, number 5, your trigeminal nerve is a sensory component. And then your facial nerve, 7 cranial nerve, is your motor component. So what you're trying to see is that if you tap on it, usually normal, there won't be anything. Alright, but if you tap on it, there will be an uncontrolled, automated, like jerk like that. You go back and see the YouTube video. Alright, then that is considered it's coming from the brain. The pathology is from the brain. Okay, understand so far? Everybody follow? Alright, so that's for the reflex. Then you check for the sensation. Alright, use an orange stick. Yang ni tajam, show them first. This tajam, yang ni tak tajam. Okay, yang ni rasa dah tajam. Okay, and then after that you're gonna place it on their hands. So only one point. Alright, you follow the Asia chart. C5 here, lateral elbow. C5, C6, tip of your thumb. C7, C8, T1. No need to check all these points. No need. Just 5 points. Save your time, and that is the most accurate one. Okay, alright. C5, C6, C7, C8, T1. Alright. So of course, then after that you're gonna complete with your lower limb neurological examination. Okay, so let me show you. Can you just slide up? Yeah, take that. We can take up your shoes also. You come down a bit. Okay. Similarly, tone, power, reflex, sensation. Tone. Okay. Alright. Then power. Can you just leave it up straight? Don't let me push it down. So Prof. Kwan always said you need to use both hands. If you use one hand, you are like actually disrespecting the patient. You are saying that they are weak and all that. Alright. Okay. Alright. This is to test which nerve? L?
L2.
L2. Alright, L2. Then you compare both sides. Then after that, lift it up. Don't let me push it down. Lift it up. L3. Okay? Alright. So, you don't ask them to, like, for example, you do this and then after that, straight away push. So, whatever that I'm demonstrating to you now is the correct and the order follow exactly the same. Alright? Okay, so again, L2. Lift it up straight. 2 hands. Don't let me push it down. Then you compare this side. Don't let me push it down. L3, go straight. Don't let me push it down. Here, you see where I place my hand and all that. Don't let me push it down. L3. Okay. Now, dua-dua buku lali boleh naik tak? Buku lali, Okay. So, L4. Don't let me push it down. You see, like this. Now, some people do variation. Some do like that. Some do like that. No, just do like this. L4. Okay, now the next one. Big toe, go up. Don't let me push it down. Big toe, go up. L5. Okay, now then this one usually I check one by one for S1. Okay, sekarang boleh tekan brake. Tekan brake. Kuat. Jangan bagi saya tolak ke atas. Stabilize here. Tolak ke atas. Stabilize here. Tolak ke atas. Okay, now when the patient cannot do any of this, then after that you eliminate the gravity by doing that and you lift it up because there's a friction between your foot and the bed. So lift it up, now gravity is eliminated. See whether they can do dorsiflexion and plantar flexion and big toe or not. Okay, understand? Don't power. Now reflex. Last time when I was in medical school, I was taught this way, right? Like this, and after that hit on it. But ever since I'm trained in the UM, so I've already changed my way to like this. I just follow spine timbering style. Alright. So look at the quadriceps. See whether there's any contraction. Palpate the hamstring. See whether it is tense or not. If it is too tense, you won't be able to get a good reflection. Alright, because it's too tense already. Alright. So look at here. Your hand palpate here. After that, hit on the patella tendon. That should be normal reflex, a bit of an extension. Okay, now similarly here, just relax, palpate the hamstring, look at the quadriceps, tap on the patella tendon. Okay, then after that you go for your ankle reflex. Alright, so relax here, And then after that, here, go up. Okay, use a patella tendon, hit on the Achilles tendon here. Then there'll be a plantar flexion. Okay, reflex. Then after that, usually at this point, because I'm using a tendon hammer already, so I straight away do a Babinski. Babinski from medial to lateral or from lateral to medial? Lateral to medial. Alright, and then if upper motor neuron lesion, it will go up. Alright, normal, it doesn't move or it just go down. Down going. And after that, you do your Clonus. Because now you're at the ankle, then you do your Clonus. Clonus is like how? Relax, lift it up. And then a quick one, 3 times. See whether there's any Clonus or not. Alright? So Clonus means that it's an upper motor neuron lesion. Okay? So tone, power, reflex, now check sensation. Okay? So if you see your power, you check from L2 to S1. But your sensation, you check from L1 to S1. Okay? Similarly, tajam atau tak tajam. Kalau dapat rasa tajam, terus bagi tahu saya. Okay? So L1 here, the top superior third of your thigh. Middle third of your thigh, L2. Inferior third of your thigh, L3. Okay? L1, L2, L3. L4, 1 point, medial malleolus. L4. Alright. L5, over the dorsum of your foot. S1, lateral malleolus. So only 1 point you see, every time I check sensation. L1, L2, L3, L4, L5, S1. Okay? Alright. Then you say, I would like to end my examination by doing a digital rectal examination, okay? To check for deep anal sensation, superficial perianal sensation, and also your anal tone. That's what you want to check in your digital rectal examination, okay? And then after that, you want to mention, I would also like to check for other potential sites of metastasis. Alright, so usually what are the 5 sites of potential primary site of metastasis? Breast, lung, thyroid, kidney, prostate. Right, breast, lung, thyroid, kidney, prostate. So you adjust this sentence according to the gender that you are checking. If male patient, then you just say, I would also like to check the patient's lung, thyroid, kidney, and prostate. If it is a female patient, breast, lung, thyroid, and kidney. Okay. Alright, okay. Alright, thank you. So when you want to summarize the findings of the cervical myelopathy, you do it with this sentence. From my physical examination, the relevant positive findings include an upper motor neuron lesion affecting bilateral upper limb. Okay, usually myelopathy will affect both sides. Alright, if it's a radiculopathy, it affects unilateral side. Okay, so from my physical examination, relevant positive findings include an upper motor neuron lesion affecting bilateral upper limb with the most likely pathology at what and what, depends on your sensation and all, whatever that is lost. Alright, as evidenced by hypertonia, hyperreflexia, and then weakness in what, C5, C6 or what, depending on your physical examination, and loss of sensation over what and what area. Okay, so that's how you summarize your findings. So I think that's good enough. Alright, then if the patient has got gait instability, yeah, a patient also demonstrated unstable gait and unable to perform the heel to toe walking. Just like that. Simple. Everybody got the this one, upper motor neuron lesion. Alright, so now so what's a provisional diagnosis? So in such kind of case, provisional diagnosis will be your cervical myelopathy. That's all. As simple as that. Cervical myelopathy. Now your differential diagnosis. Alright, now you write, can be a referred pain from the shoulder. Okay, referred pain from the shoulder. Now your second differential diagnosis, you can put peripheral neuropathy. For example, that's affecting your median nerve because it can kind of mimic, right? Median nerve, these 3 fingers. And then if you got a C6, C7 pathology, it may more or less look like C6 and C7. But actually it's very much different one, which I'm going to show you in hand examination later. Alright, C6, C7. So you can say, yeah, why not? Could be a carpal tunnel or a peripheral neuropathy, carpal tunnel or the pronator teres syndrome. Brachial neuritis, why not? Brachial neuritis because brachial plexus from C5 to T1 So if you got a neuritis, can affect any of these nerve roots. And then lastly, thoracic outlet syndrome. Don't forget thoracic outlet syndrome. Your sensation and your sensation and motor and all that will be very patchy. Sometimes affect this a bit, that a bit, not very really tally with all your findings, so it's a bit difficult. Alright, thoracic outlet syndrome. But just mention as one of your differential diagnoses. Now, the next question they will ask you, then what are the possible causes of cervical myelopathy? You see, it's slightly different, you know. Alright, so provisional cervical myelopathy, then differentiate is all the other possible causes. Then after that, you go back to your cervical myelopathy because it can be due to trauma, infection, tumor, and degenerative causes. Causes of cervical myelopathy: trauma, infection, tumor, and degenerative causes. I think up to this, that will be good enough. But of course, for us like master students and all that, then we need to tell what tumor and all that spinal cord tumor go in, medullary, intradural, extradural, which I, for your level, don't have to know. Alright. So next, you want to order investigation. So what are the investigation you want to order? What radiograph? Cervical, in AP and lateral. Alright. I would prefer the sentence of plain radiograph rather than X-ray. Okay. So I think if you want to sound confident, you just say, I would like to order. I will order a plain radiograph of patient's cervical spine in AP and lateral view. Okay. Now what do you want to see? What are the 5 things Prof. Khan always say in radiograph? Anybody? Come, just alignment. You want to look at the alignment, isn't it? So any loss of the cervical lordosis from the X-ray, right? Number 2, you want to see is there any calcification, all right? So in cervical myelopathy, maybe it can be associated with your ossification of the posterior longitudinal ligament, OPLL, all right? So that's what you want to see. Number 3, you want to see if there's any end plate erosion, because just now you see your possible causes of cervical myelopathy is infection. So end plate erosion for infection. Number 4, tumor. So tumor, what do you see? Pedicle erosion. Very good. All right. And then number 5, you want to see any spondylolisthesis. Okay. So cervical spondylosis, degenerative causes, then they could there'll be a translation. Your spondylolisthesis. Now, of course, in a very typical cervical myelopathy, secondary to the cervical spondylosis cases, you'll be able to see the reduced in the intervertebral disc space as well. The disc space is reduced with spondylolisthesis. It's a very characteristic features, all right? So if the patient has got a neurology, so what is the next imaging modality you want to order? MRI. MRI cervical. No need contrast unless you suspect it's a tumor case. Alright? MRI cervical spine. No need whole spine, just cervical spine because that's your pathology. Alright? But of course, if your jaw jerk is positive also, you also want to order? Yeah. But usually just MRI brain straight away. MRI brain and cervical. So the MRI findings you don't really have to know for your level. As you can say, to determine the nature and the severity of compression. That's all. Good enough. Alright. Then after that, management is always conservative and surgical. So conservative, standard lah. Rest, activity modification, back care, back exercise, your physiotherapy, and then you can give some neuropathic medication. What are the common neuropathic medication we give in orthopedics? Yeah, I heard something. Yeah, gabapentin, pregabalin, right? These are the common neuropathic medication for shooting kind of nerve pain, all right? And of course, you top it up with the anti-inflammatory medication. Rarely we give tramadol and all that, but rather when there is an irritation of the nerve root, it will cause inflammation. And hence, you usually give Capcelebrex 200 mg BD for our patient for short term, and sometimes can top it up with steroids as well. For example, Tetexa or Teprednisolone. Okay, alright. So, if there is a failure of this conservative treatment, then you go for surgery. Alright. So you don't know what, no need to know what kind of surgery. Alright. We're gonna decompress. Alright, so up to this part, any question? Physical examination, that's what you do. That's how you summarize. These are the provisional and differential diagnosis that you need to give. Alright. And then these are the standard investigation we will do. And management. Alright. Yeah. Yeah, I mean, it would be good to know. Alright. So, now we are using MJOA score, Modified Japanese Orthopedic Association score. Alright. Last time they used this Japanese Orthopedic Association score. There are a few differences. MJOA, the total score is 18. For JOA, the total score is only 17. And for the original JOA, they use chopstick because it's Japanese. Alright. But in order to make it more universal, then they change it to chopstick, fork and spoon. Alright. So that is one of the differences. Then the total points is different. The component also a bit different. Alright. So for original JOA, they talk about motor, upper limb, motor, lower limb. Sensory, upper limb, trunk, and lower limb. And bladder and bowel. Okay, so these are the components for JOA. For MJOA, only 4 components. Upper limb motor, lower limb motor. Sensory, they only check upper limb. Then bladder and bowel. Okay, alright. So just remember one enough already. You can say, yeah, I would like to use an MJOA score to calculate that. And these are the 4 components. So the cutoff point, 13 and less, strongly encouraged for surgery. 14 and 15, advised for surgery. 16 and above, conservative. Okay, that's how it's going to guide your management. Again, you just mentioned you want to use an MJOA score, calculate the MJOA score based on these 4 components. Upper limb motor, lower limb motor, upper limb sensory, and bladder and bowel. 13 and less, strongly advised for surgery. 14, 15, advised for surgery. 16 to 18, conservative treatment. Okay? Alright. Now, another question that they might ask you is, what is the natural history of cervical myelopathy? How is the progression like? Anybody know? It's a stepwise progression. Stepwise means like this. Stepwise. Alright? So that means that you'll be stable for a period, then sudden deterioration. Then stable for a long period, then sudden deterioration. Alright? So if you can answer this question stepwise, then they're gonna ask you, why is it stepwise? Because it is vascular in nature. Just like your dementia, vascular dementia. All those elderly, the vascular dementia, quite stable, then tiba-tiba they got an infarct, then it deteriorates. Then after that it remains stable for a period of time. Then another infarct, then deteriorate, then after that stable. So it's vascular in nature. It's the infarct to your spinal cord. Okay, alright.